So this is one of my newer cases. I have only actually met with him in person once, but I've talked with mom several times. The client in question, he is a 12-year-old male. He is the oldest of four. He has three smaller siblings. I believe they are 7, 3, and the littlest one is a baby. I would say 6 months or so. All of the children have various special needs. Mom is a single mom. She does have grandma as support. Um, the biggest issues with him, mom claims she's never been able to get a full psychological evaluation. I don't know the validity of that because mom also told me that they had RAP services previously and the provider just stopped coming. And when I checked into that, they were successfully discharged from RAP before. The impression that I've gotten from that, though, is that that was before the youngest sibling was born and that his behavior has escalated a lot since then. She contacted us because he is defecating on himself and then refusing to clean it up. And now he's doing it at school. And now the school has demanded that he wear pull ups or he's not coming. That has sort of gone okay so far, but he is still exhibiting the behavior. Um, he also does not take responsibility for any of his actions at all. Everything he does, he says it's his mom's fault. It's because she doesn't love him enough. Mom and grandma both stated to me when I did my home visit that they have actually had previous service providers say that to him in front of him and his siblings that everything was mom's fault. Um, he has been in trouble with school. He had a youth service worker come in. They dropped off too. It was a lot of, if you don't straighten up, this or that's going to happen, and then no follow through. She did tell me that he was denied IDD waiver because he has about a 70 IQ, so he's hitting at borderline intellectual functioning. Um, I've given her the application for the CSED waiver, but all that he is actually diagnosed with is ADHD. I think there is more going on there than just that. But at this point, that's all he is confirmed of having. Mom said that there's pretty much nothing that seems to make him happy, even if he gets access to what he wants when he wants it. That only does him for about 5 minutes, and then he's back complaining and picking on his siblings. And um, mom denies any kind of trauma history. The only thing that she said was that his dad's not in the picture and never has been. The younger kid's dad is around and he does try to interact with him and do things with him, but that has become less so as the behavior has escalated. Mom's also said that other agencies won't come in and work with her other kids because of his behavior and his physical aggression when they do come into the home. Um, Mom's also concerned because the younger children, the 3-year-old and the 7-year-old, are copying his behavior because nothing works when she's tried to discipline him for his behavior. So they're seeing Big Brother get away with it. So now they're doing the same thing. Um, he's also called CPS on mom before, saying that he's being abused, and they come out and they check it. And of course, nothing's going on. There's food in the house. They have everything that they need. Um, they're actually getting services through Chestnut Ridge. That was who referred them to us. Um, but I really don't know what to do with this one. He's just very angry at mom, and mom doesn't really seem to have any idea why. Um,
He has been medically evaluated. There seems to be no medical reason that he's defecating on himself. So any suggestions anyone has, I am more than willing to hear, because mom is really kind of at the end of her rope and doesn't want to put him in placement, but she's not sure what else to do for the safety of her and the other kids just because of his size and his anger.
So I wanted to add a little bit of this because I think I'm responsible for the referral, Cheryl.
Uh-oh.
I actually have not met the family, but the resident doctors and the team that were caring for this family at Chestnut Ridge were very overwhelmed with mom and her level of distress. And we were really talking about, so I heard about the case sort of through different venues, and I think one of the things that came from that end was how distressed mom was. There was concern kind of about how mom was coping, and attachment.
Mom has already admitted that she has severe anxiety and depression and PTSD and has been hospitalized herself before.
And so there was really a lot of worry that I mean, she was even sort of accusing the team of not trusting her, and they actually were really supportive of her and trying to figure it out. And I think one of the wishes on their end was it was also very hard to get information from mom about that sort of PBS concept of understanding the behavior, what was coming before the behavior, what was the behavior, and sort of was the outcome of the behavior, because she was so distressed. I mean, she was actually asking for a referral for out of home was how she led most of the visit. Like, I'm done with him. I can't do this anymore. Was sort of how most of the visits kind of went early on. And so I think a lot of the medicine visits were sort of, this is a challenge, I think, in child world. And I'm glad, Jenna, you were on here as well. But, you know, you're managing the parents' mental health and stress level alongside trying to get an accurate assessment of the child. And I think the reality is, from the Chestnut Ridge side, that mom's affect was so intensely overwhelming in the room that it got in the way of much sort of real information that could be obtained from the child, and it was hard to get a reliable report about what actually was going on because of this level of distress. And so that, I think, was the most overwhelming thing. The most overwhelming behavior was, of course, the pooping, but there was also a concern that I think came out of this is sort of not knowing, and again, mom has an array of kids with different needs and special needs, that there may have also been kind of, and we knew he had borderline intellectual abilities, that maybe she didn't understand what his capacity was. And so there was a real sort of question about some expectations that maybe he could do things independently, again, trying to relieve her from the care of the younger children, but really not that he really wasn't able to I mean, again, the pooping sort of aside, but there was a lot of expectation that he could be a lot more independent, a lot of activities, and didn't still need a good level of supervision and teaching. And so those were sort of the three big sort of domains that kind of came up. And there was a lot of hopelessness, and there was a lot of, I've tried everything, nothing will work, when it was also, like you said, very hard to even get that there'd been any intervention, because it seems like every visit had been kind of this crisis, kind of desperate sort of thing. And also being mindful that there had been a lot of kind of referrals made. And so really glad to hear she followed up with the PBS referral because had sort of declined other sort of interventions. And so I'm really glad to hear she made it to you. I think,
well, don't be overly hopeful yet, because she's canceled twice on me, and she just canceled again today. We're tentatively set again for next week. She did say today was because two of the other children were sick. And I get it.
Life happens, kids get sick, but I am also worried about her follow through, just because she has so much on her plate with all of the kids, and she's a CNA. And
I don't know. I think there was a lot of, so I think I'm hoping Jenna can add a lot to this, but I think from my perspective, there was just so much trust building that needed sort of made with mom. I mean, there was, she doesn't let people in easily to help her. I think it feels like an insult. And so I think it's really hard for her to accept help. But also I think when she's let people in before, she's not felt it helpful, but
That's what I got from her. Yeah.
pushing away sort of mentality. And so I think sort of the clear end from our perspective was what we had. We knew that there was no magic pill or medication that was going to fix it, and that really getting to the heart of understanding the behaviors and getting good diagnostics and understanding the patterns was really where we were. And so that's my little backstory, and I will turn it over to the group to see what they think.
Cheryl, I thought this was a really fascinating case, mostly because this kid is just before I think I would normally see him. And I imagine Katina's over there going, oh yeah, I've seen him in 10 years from now, and I know what's coming down the road if something doesn't change pretty quickly. So I had some questions for you. Any prenatal issues? No. Okay, no prenatal alcohol use.
Mm-mm.
This was screaming that neurodevelopmental disorder, Lauren, that oh gosh, it's a long one. Due to prenatal alcohol exposure, neurobehavioral disorder.
Neurocognitive disorder secondary to prenatal alcohol exposure.
It goes forever. And I was thinking the same thing as Lauren. Like, I would want a functional assessment of this kid's behavior. I would just really want to understand those antecedents. And I see that there's a lot more family stuff going on than maybe I perceived when I was first reading this. I'm really interested about this borderline IQ, yet when police come to see him, they're perceiving him as so low functioning that they can't handle him. That doesn't strike, that's not your average borderline IQ individual. The police can handle I mean, most of these kids, well, at least the adults that they're handling, we have lots of people in the 60s and 70s, and police don't think twice about like handling the situation. So in my head, I was going, is he coming across lower functioning? And then the thought of like, IQ is not just, or his IQ should be about his adaptive behavior, not just this. And so what kind of full evaluation, mom's saying he didn't get that full psychological to really take into consideration his adaptive assessment, rather than just, oh, on the IQ test, he got this score. Although I know waiver is just very difficult to obtain anyways. Sorry, the one thing I was thinking that you could give mom pretty easily is the number for that mobile crisis hotline that the state is.
Yeah.
You've done that, okay. Because I was like, wow, if she's calling the police so much, maybe if she calls this number, I don't know how helpful. I haven't had patients to call, but this case is the exact case that DHHR is trying to avoid, or they're trying to fix, because they're they have this big mission to stop sending kids to placements that don't need placements with other levels of services. And so like this is your like poster child of, well, what do we do? What other services do we have? So yeah, the functional assessment was the first thing I was thinking about. What about getting mom her own therapy? Was that a question or a thought before, Lauren?
I don't know that mom is getting therapy. I do think that she is seeing someone to be medicated for it, but I don't know that she's actually doing therapy.
It seemed like with all the questions of how she's functioning.
I don't know. We talked about, that was sort of a larger question. When you really see the parent struggling, how do you offer help in a way that isn't insulting to them? And she clearly sort of takes sort of attempts, I think, to be helpful sometimes as blame, which is really what we were trying to avoid. So I don't even think we kind of got there. As I said, my understanding when the resident sort of was inquiring how mom was doing, she took that pretty poorly actually, and sort of projected back that that wasn't really a question of empathy and concern for her, but more of a you're blaming me sort of perception. And so we didn't even go there. I think it was really fragile. And most appointments would be long, but would kind of end in this exasperated, well, no one's going to help me anyway, and just kind of leaving, even though we had talked about things. So this has clearly been something that maybe being recreated with you, Cheryl, like this magic hope that this is going to get better, and I'm just missing the quick fix, when I think the answer is this is going to be a long-term thing that you got to really dig in and understand and build that trust, because it's took a long time to get here, and it's probably going to take a long time to undo. And I as I said, it was, again, I did not meet her. I had a whole team of exasperated folks that just really didn't know how to help them, and really trying to think about, because she's very problem oriented and sort of behavioral oriented. There wasn't a lot of curiosity about sort of the whys, I guess, but I think that was maybe beyond what she could tolerate. And so sort of thinking of that PBS approach of trying to get her to see the behavior as a result of something else that we would like to understand, so we could really help the cause, was sort of my magical wish.
You know, Cheryl, this case, if I were you, I would feel totally overwhelmed and with a big, like, oh my gosh, where do I even start? So, and one thing that helps me, especially, it sounds like mom is really defensive, would just be like, you're not doing any work yet. You're just doing the engagement piece. So you are really connecting with mom and just listening to her. If she's in survival mode, just needing to talk about all the problems that she's going through and really needs you to believe her, then I would sit with that for a while. And then hopefully you'll get some of that history. That sounds like you don't have a good history, but just focusing on the engagement. I feel like if you try to do any work right now, she's going to push back real hard because you don't understand what she's going through. So taking the time to just sit with the engagement piece, and then kind of the same for the patient, for the guy. And I would separate them, because it doesn't sound like mom's going to give him the space to voice his own anything, and she'll probably be dumping a lot on him. So I would just sit with the engagement for a while, and then if you're successful with that, then you can move towards some of the doing. That would be my advice. And that feels less overwhelming to me, because I'm like, okay, I can do the engagement piece. We were just going to listen. We're going to ask you questions. I'm not going to even go towards them. Well, why do you think this is happening? Just be like, okay, tell me more about how this affects you. And I can do that. And then you get to the other stuff later.
Thank you all so much. And Anastasia, I noticed you had chatted in. Did you want to expand on the recreational places and the data forms?
I'm not sure if Cheryl got a chance to talk to her about those yet, since I think you were planning on it maybe on this home visit, Cheryl, about the Disability Action Center in Fairmont and YMCA. But I was wondering if they have transportation to even get to some of those like recreational type of things. And I know we talked before too about like connecting her to other parents. I don't know if that could be a good thing or a bad thing, because I could see it going either way. I mean, yeah, I was wondering about the ABC data forms. If you think it would be too overwhelming, because I imagine it would be in some regard, but then on the other hand, I can see where maybe it'd start to get her thinking about the ABCs of behavior. So I just sort of wanting to get everybody's thoughts on that.
My first visit with mom was pretty much just letting her talk, trying to get as much information about what was going on and what she was dealing with.
I've given her the information for mobile crisis. I passed along the information about the Triple P seminars. I am bringing her a new RAP referral. I'm going to try and get them back involved. I've also given her the information to do a fast referral, because I think there's more that the school could be doing that they're not to help address this there too. And honestly, I'm kind of surprised they've not already gone into this given what he's doing at school, but
And I wonder, Cheryl, if it would be possible to make contact with the person, the wraparound that was in there for 17 months and she successfully discharged him. I wonder what plan or what was the final resolution then that made it a successful discharge. You know what I mean?
That was my thinking, is that I needed to follow back up with Angelica, the supervisor for that area, and see if she could give me more information on their past history and see where we need to go from there.
I mean, the chances too, I mean, usually sometimes those positions have a high turnaround rate. You know, she might not even be there anymore, but I would just be curious to know what did they define as a successful discharge and what was some of their strategies and interventions they did that made it successful.
Maybe that can give you some strengths of the patient and the mom, or things that were, yeah, like Mariah said, really helpful to them, so you don't have to reinvent that wheel. My thought, and I don't know the system enough, so I'm gonna look to Lauren to answer this question. Is there a way to get this child a psychological evaluation?
Well, sure, although I actually think there probably is one already done. I just don't think we've had it. If he's already gone through the process of IDD waiver and we knew he had been denied because the IQ was 71, there's some aspect of testing that's already been done. So getting a look at that kind of more formally would be helpful. Also, again, probably to start with, if there's not, I mean, we have a couple of options. We could always sort of go back to the school. School will repeat psychologicals and can certainly do that if the time frame's been off. And we could also refer him to neuropsychological testing. But in order to get the full neuropsychological testing approved, you really have to demonstrate like a clear underlying medical cause, or they'll deny it on the insurance end if there's not kind of either a genetic syndrome or epilepsy or history of in utero exposure. They'll tend to defer and ask for more of the school-based psychological first. So I think, and again, I don't know that, I don't even know that the conversations got that far to hunt down past testing. I think, you know, this is also, you know, you all know this is sort of that frustrating point with that separating out functionality from IQ is that the IDD waiver is so strapped for services right now that you have to have pretty, if your IQ is above 55 and you don't have severe functional impairment, you get denied even for those services. And again, I think I don't know, but the impression was she again felt so rejected from her last attempt at getting a waiver and thinking that it was hard to even kind of go there. So I know there's been some type of testing before to get his IQ there, but I've never seen it. I don't know that our providers have seen it, and I don't ultimately know who did it, or that was just a number she gave. So, but yeah, I think certainly that could be repeated. You know, he may ultimately, I think the other area we sort of went down, although as I said, understanding the behavior, I think made it really challenging to get to like a correct psychiatric diagnosis for him and at this point. But you know, the other thing is, was he getting to a point, especially with the threat to take him out of home, with something like the SED waiver, which is that new serious emotional disturbed waiver for kids with sort of chronic mental health issues. And that's also a referral option that would repeat the testing, because they repeat psychological testing as part of that process. I really talked to Anastasia, and she told me that she was really good with poop. And since that was like all we had, I was, I guess, hoping that more of a behavioral intervention looking at that would kind of, as I said, she was, the poop is a very big, I mean, as I said, like talking about like poop and behaviorals around poop and why kids like do that is such a multifactorial task that, as I said, I'm not sure we got into a whole lot of the other things going on other than that this poop is really huge for her. And so I think in sort of the discussion about where can we go, thinking we get him in PBS faster, and just this need to get the poop under control was sort of the thought. But you know, SCD waiver might really be another sort of route.
But will they consider him when he doesn't have any mental health diagnoses?
Well, he does. The ADHD is a mental health diagnosis. The incoparesis is a mental health diagnosis. As I said, again, the requirements is a mental health diagnosis and risk of out-of-home placement. So I think they would at least start the assessment. Again, part of the assessment is going through it in terms of the application. I think, to be honest, I think that the PBS form was a much easier thing for her to engage in than what it might take for her to fill out the whole SCD waiver sort of package. And again, I think a big part of this was just feeling like they didn't have any therapeutic support, and we were kind of like, well, however we can, how can we get it in the easiest, gentle way that she'll sort of accept it? Because as I said, it was really overwhelming. It was really overwhelming for our trainees on our end to just how to help her. So I just think PBS is so nice. So that's how you got picked.
Hey, Cheryl, I was wondering too, does he have Medicaid already?
Yes.
Okay, cool. Because I talked to Heather Cummings with CSED waiver recently, and she said that they have to have Medicaid to apply for it. And another thing I was wondering, because I know whenever we've had people that were smearing before, a lot of them had lower IQs as far as like the sensory component of doing some kind of with something similar as far as like finger paints or pudding or that kind of stuff. So do you think that there's like an attention component of it, or for the smearing?
I don't really know at this point, but the feeling that I've kind of gotten just based on what Mom told me and just the overall feeling between her and Grandma in the house is that things were okay enough until
The youngest one came along. And then it seems that since that one came along, that's when everything has just kind of escalated back to a point that she can't cope. And I do think part of it may be attention on his end, because now Mom is focusing that attention on the baby and he's not getting as much. And then I think the 3-year-old had something happen when they were born, and like they had a stroke, and there may be some cerebral palsy going on there now. So that child's getting more attention. And then the next one up, I think, is the one that won't eat. So that one gets extra special attention because of that. And I think that part of it may be because he wasn't the one getting all the attention anymore. And this was a great way for him to be able to get that for Mom and other people.
I also question, and as I said, I don't have any information to support this or not, but another common thing we see with the pooping with ADHD is kids aren't paying attention to their body function, and they just hold it, and then it kind of comes out when they don't think about it because they're not in tune, or they're inattentive, or they get hyper focused when they're doing something fun. And so, you know, and I think that was other sort of missing information. Like it was very unclear, even the details around the pooping. Was he just pooping in his underwear, and that was causing distress and not realizing it, versus I don't even know how much it was smearing or other things. As I said, it was just the poop, and we couldn't get any details about it. And so, like, you know, like it was just, and again, she was very overwhelmed by the poop because it would take her attention away from other things. But like, I have no idea, like, the kid's perspective on it at all. Like I couldn't tell you if he was aware of it. I couldn't tell you if he could feel it. I don't even know if he had an opinion on it. Like, no, zero clue about like the patient view on it. That was such like a missing part. And again, some of that was because, I mean, the visits were essentially mom, and you're like watching the kid because there's no like time to really engage the kid or ask. And it was, yeah. So, yeah.
Thank you all so much. This has been such a wonderful discussion. We are about halfway through the session time. Were there any other comments, thoughts, or feedback for Cheryl in the case? And Cheryl, did you have any other questions or things you wanted addressed about this case specifically?
Not that I can think of at the moment, but I'm sure I'll have more after I visit with them again.
Absolutely.
We're going to need an update, Cheryl. We need a poop update.
Yes. We can do a follow-up. We'll see what happens. Do another case presentation.
We truly appreciate it, Cheryl. Thank you so much for another great case presentation. And like everyone's encouraging, if you have a follow-up for the same case, that's always welcomed. If anyone has any other cases or even just questions, feel free to submit them through that online form that Elizabeth and I send out in our recaps and everything. But all right, if there are any other further questions or feedback for Cheryl in that case, just feel free to shoot me an email or continue chatting it in live during this session. But just for purposes of time, Dr. Swagger, I'll turn things over to you. I'll make you co-host so that you can share your screen and do your PowerPoint. I also have it on my end if you'd like me to pull it up.
Well, hi, everybody. I'm going to switch back to, we had started back in March, sort of a rapid review of sort of psychopharmacology. And so we're just going to touch base and see how many categories of medicines we get through today and can continue from there. I know someone had requested something specifically a little bit more on OCD as well. And so we're going to start with antidepressant medications today. And so I will highlight some of the medicine things regarding OCD for that. And as I said, we can continue bits of this throughout. So this is actually the same PowerPoint that was from March. We're just starting on slide 17. So let me share. Whoop. All right, can everybody see that one okay? Okay, so this is a slide with a lot of crazy names on it, but it's sort of to reflect that there are a lot of different types of antidepressants. And so we use that word and we can mean a lot of different things. So antidepressants fall in certain types of classes based on how they work pharmacologically and how they sort of deal with sort of different neurotransmitters and their mechanism of action. And so some of the more common sort of theories are sort of the dopamine, norepinephrine, and serotonin theory of how psychopharmacology works, although that is a limited, narrow view of it. But some of our medicines in this group really do work that way. So the most common class is the selective serotonin reuptake inhibitors. So when I say serotonin, I want you to think about tryptophan and turkey and sort of the relaxation hormone that often helps with anxiety as well as sadness. So it's sort of, you hear serotonin, you think sort of targeting depressive symptoms, sadness, irritability, and anxiety. Then you have selective serotonin and norepinephrine inhibitors. Those increase both serotonin and norepinephrine. Norepinephrine is a little bit more involved in focus, concentration, and energy sort of aspects of depression. But serotonin and norepinephrine together both also really can tackle anxiety as well. So when we use the word antidepressant, many of these medications also treat anxiety disorders as well. So SSRIs and SNRIs are all pretty good anxiety medications as well as antidepressants. Monoamine oxidase inhibitors are old school medications that actually increase all three. dopamine, norepinephrine, and serotonin. And if norepinephrine is the gentler version of concentration and focus and energy, dopamine is a much stronger sort of agent that sort of increases energy, focus, motivation. So monoamine oxidase inhibitors can be used for both depression and anxiety. You don't see these used a whole lot anymore. These are the medicines that had all the diet warnings, so people couldn't eat chocolate or drink wine, and they have a lot of drug-drug interactions. So we rarely see those in adults, and we rarely see them in kids, but I wanted to have them be on the list to be complete. Tricyclic antidepressants are actually like SNRIs. They increase both serotonin and norepinephrine, but each one does a little bit more than the other. So some of them mimic different things, like clomipramine on this list actually is pretty serotonergic. So it actually looks a whole lot like an SSRI. Tricyclic antidepressants, again, are older, have more side effects, but they do have some unique sort of abilities in kids that we'll talk about. We certainly use clomipramine for OCD, which is one of the things we'll talk about. And you'll see sometimes Elavil or amitriptyline being used for migraine, headaches, or pain. Those systems are all involved in that. And actually, although we were talking about poop earlier, on the peeing end of this, like kids that wet the bed, sometimes tricyclic antidepressants can help with bedwetting, which is sort of because, again, some of these cycles with norepinephrine and dopamine actually impact both the peeing sort of reflex and the pooping reflex. So sometimes those can be impacted as well. And then you have some other categories that all have kind of their unique action. Bupropion on this list as well, Butrin or Zyban. This is a very interesting medicine, but it targets, actually it's a very unique one. It targets norepinephrine and dopamine. It does not have a lot of serotonergic action. So it is actually one that's really a pure antidepressant and not very good at all for anxiety. But if you know what Zyban is, you know that this medicine is much stronger at dopamine because it's involved in a lot of things involving addiction pathways. So bupropion is used for smoking cessation and tobacco cessation and has some data for children in that regard. And it's also used in things that help with like binge eating and cut appetite and some of the other sort of more addiction-driven pathways because of that dopamine effect. Trazodone and Remeron are sort of heterocyclic compounds that work in kind of different ways with norepinephrine and serotonin. They're commonly used in sleep. On this list, very few are fully approved for kids. So I'm going to just highlight the ones we really know and have great data for in kids. So actually, pediatric OCD is probably the most well-studied pharmacologically, only second to ADHD in the kid world. We know a lot about medications for OCD, and there are 4 medicines that are approved for pediatric OCD: Lexapro, Prozac, Luvox, and clomipramine. For depression, we have 2 SSRIs that are approved. Lexapro and Prozac are approved for pediatric depression with a little bit of a split in age. So Prozac, it goes down to age 7, Lexapro to age 12. And some of that is probably related to, again, remember, kids don't develop these serotonin, norepinephrine, and dopamine pathways all at the same time. And the serotonin pathways in our bodies don't really get fully developed till about mid-20s. And kids don't metabolize things the same way adults do until about 15 or 16. So when you're thinking about these types of medicines in kids, age really matters. And if you go too fast with the dose or you give too much serotonin, anyone want to guess what a super serotonergic child looks like? Any guesses? No guesses? Oh, come on, this one's fun. If I give a little 7-year-old too much serotonin, what are they going to come in my office looking like the next time?
Maybe really hyper.
Yeah, they look like they have ADHD. And you're like, oh, did I get your diagnosis wrong? No, I gave you too much serotonin. So you do have to be cautious with these medicines, especially in the young ones. And then Cymbalta or duloxetine, which is the SNRI one, is actually approved for pediatric generalized anxiety disorder. Now, for those of you that did not hear the earlier part of this talk, I just also want to tell you that FDA approval is fabulous, but it does not mean that we don't have evidence for the other things. So one of the most striking examples of that, although duloxetine has an indication for pediatric generalized anxiety disorder, and actually is the only medicine approved for generalized anxiety disorder in kids, it actually does not have the most data. The most data actually goes to Zoloft for anxiety disorders in kids. It just was generic when most of those studies were done. And so the company did not go after an FDA indication. But if you look at most studies of pediatric anxiety, you're probably going to see an SSRI used instead of an antidepressant. Okay, so sometimes that's a little bit complicated. All right. Anyway. And so this is just a little bit of a review, how we might use them. But as I said, if you think about these biologically, you can certainly think about SSRIs for other reasons. And also dosing really matters. And this is where that it kind of depends. And so we'll talk about that a little bit. But, you know, again, when you think about sort of key symptoms, you know, panic attacks, really rooted in serotonin cycles where you get stuck autonomic discharge. And the medicines that really seem to break that cycle is a serotonergic medicine. So for kids with panic attacks or panic disorder, we usually prefer SSRI medication. Irritability, we talk about vagueness from our case today, when people just give you vague symptoms and you really don't know, you're trying to understand it, but a really common symptom is just, my kid is just irritable, everything gets on their nerves, everything's on edge, and it's a really profound symptom, but it may be the most notable. Well, irritability can be like present in almost anything in child and adolescent psychiatry. It can be present in ADHD, it can be present in bipolar disorder, it can be present in trauma, but really persistent irritability really has some strong links to depression. And if there really is not clear evidence of mania or something else, sometimes we use SSRIs to target this profoundly dysfunctional symptom of irritability, because sometimes parents will describe that far more than they will describe sadness. PTSD is sort of questionable with these, and a lot of data with kids, medicines are not helpful for core PTSD symptoms. So that's why there's a question mark there. When you think about things like flashbacks, nightmares, hypervigilance, SSRIs actually don't help. They're actually terrible failures at those three symptoms. And so when you look at kids studies, and that's not true for adults, those medicines in adults have demonstrated an improvement in those three symptoms. But in kids, there's just not a lot of evidence. And again, part of it's probably because the serotonin pathways are not super well developed. However, lots of kids will get comorbid severe anxiety and comorbid severe depression with their PTSD, and the medicine can help for that purpose. But it's targeting more the anxiety and it's targeting more the clear depression. It's not going to really address hypervigilance, flashbacks, or reoccurring intrusive thoughts from trauma. Aggression also has a lovely question mark. Aggression being that lovely vague symptom like we talked about with pooping, like you really need to figure out what's triggering the aggression and what's kind of behind it. But often, especially an irritable, moody aggression can often be a really common presentation of depression or anxiety. And many of you have heard me talk about pediatric anxiety disorders. I actually think aggression is a major unexplained cause of a lot of anxiety. And so we see profound avoidant anxiety in kids where they use the aggression to escape. So if you're talking to me, if you're, if I am so overwhelmed, I just want to leave. And this often happens at school. Kids will punch, hit, kick to just get kicked out and to avoid. And so if you really think that that aggression is coming from a place of almost panic, escape behavior, anxiety, sometimes the SSRIs can be tremendously helpful. Again, that's a lot of detective work to get there before you would jump to medicine. So it's not for aggression per se, but it's really trying to understand that avoidant anxiety that might be contributing. And as I mentioned, a lot of the SNRIs and those tricyclic antidepressants, anything with a serotonergic norepinephrine component actually can help pain as well. So duloxetine, Effexor may also have a fair amount of help for pain syndrome. In pediatric depression, we usually start with a trial of Prozac or Lexapro, usually asking if parents have had a family history of response to help guide us, but usually picking one of those two because we have the most data and thinking about those options first. But certainly there is data for other medicines for depression in kids. And so if a family member reports great responses to Zoloft or Celexa, we could still use those for depression. There's data there. Prozac by far, and because it has a very long half-life, by far has the best efficacy data for pediatric depression. And this is also where there's a difference in dosing. So as I said, many of these medicines treat both depression and pediatric anxiety, but dosing matters. With SSRIs and SNRIs, you tend to get more antidepressant effects early at lower doses. So I'm going to use Prozac as an example. While you may see a robust mood effect at 10 to 30 milligrams for Prozac, when you're talking about anxiety, especially OCD type ruminative, intensive, repetitive behaviors or intensive ruminative thinking, or you're talking about panic disorder, the higher doses really do help. And this is where understanding what you're using it for really matter, because I say the only thing sometimes that makes me feel smart or people credit me with is I just increased the dose of things because it was the right medicine. It was just the wrong dose. And again, sometimes, you know, we all want to be cautious in kids. And we, you know, a lot of pediatricians won't push the dose because they're afraid it's a kid. I don't want to push the dose. And you do need to be cautious. You have to start low and go slow, but the actual treating doses are really pretty similar to adults. So treating panic, you really need to get above Prozac 30, and you might even need to go to 80 to really target, which is the same range for adults. Same thing with all of these. If you're targeting them, you just can't do it in 1 week, or you're going to end up with a hyperactive teenager that looks like ADHD because of that lovely serotonin load, and then they'll hate you and they'll panic more. So when we're talking about slow increases, this is really over 6 to 8 weeks, usually, of slowly, steadily working up the dose so that they can tolerate it. And so dosing really matters. And then depression, you can push the dose for depression, but there's more and more studies looking at sometimes that the dose increase in depression might not be as robust as it is for anxiety. And sometimes it's comorbid. You really truly have depression isolated without anxiety. Increasing the dose may not always be as helpful as switching. And usually people recommend trying 2 SSRIs for depression first, and then switching to an SNRI. The most commonly used SNRI with data is Effexor. It is not approved for depression, but in a lot of the treatment-resistant studies for depression, switching to Effexor after failed SSRI trial was the next best step. The other thing we sometimes do is an augmentation strategy, and we may add something like bupropion or Wellbutrin for those targeted depressive symptoms. And so if you have a kid that has a nice response initially with an SSRI for depression, usually targeting sadness and irritability and tearfulness type symptoms, but they're still profoundly like anhedonic, low energy, low motivation, sometimes adding the bupropion, that Wellbutrin, with a little touch of that dopaminergic norepinephrine effect can really kind of treat the other half pharmacologically of their symptoms. So those combinations can be considered. However, Wellbutrin really can worsen panic disorder. So you have to be cautious with the addition of Wellbutrin, especially in highly anxious kids. You might get a supercharged child, much like they would have panic or intensifying of their anxiety symptoms, like with caffeine or stimulants, because it has a stimulant-like quality. So you can think about it that way. Interestingly, as another aside, because of that dopamine and norepinephrine effect of bupropion, anybody know what other pediatric condition that bupropion is sometimes used really off-label for? That's not at all related to depression or anxiety? Any guesses? Do you remember the class of medicines we covered in March? Anyone? Sometimes used as an ADHD medicine. Again, very off-label, but all stimulants have that same sort of bump in dopamine and norepinephrine too. So sometimes people use bupropion off-label, even though it's technically an antidepressant. All right, so just some brief management sort of things. Whoop, and then we will wrap up. Serotonin actually is mostly located in your gut. You got a lot more serotonin in your gut, in your bowels, than you do in your brain. And so the most common side effect is stomach aches, nausea, and sort of dry mouth. You can also get that restlessness when it's mild and the kid doesn't look like they're ADHD, they're just a little restless or can't sit still. That's called akathisia. If you go full bore, you're going to look like you have ADHD, but that response is that restlessness is too much serotonin. Sometimes sleep improves, especially ruminative worried kids or the kids that are waking up with panic actually report significant improvements in their sleep from treating anxiety and depression. But some of the long-acting ones like Prozac sometimes worsen insomnia and need to just be monitored. Although, again, it's really sort of dependent on how their sleep was affected before, because sleep disturbance is also a key symptom of anxiety and depression. These medicines really do need tapered. Prozac usually does not need tapered. It's really long half-life. It kind of self-tapers itself. So that one can usually be stopped without much problems. It's also a fabulous one if a kid doesn't remember their medicine every day because they don't feel so bad. All the other ones feel kind of crappy if you just miss a dose. And so sometimes people will kind of just feel off or flu-like, and it's subtle enough that you sometimes don't remember why you feel bad, and it really can be pretty awful. Sometimes when you've used a serotonin medicine for a long time, people get kind of the blahs. They just kind of feel the blahs. They don't describe full depression, although sometimes it could be. Sometimes they just like have this unmotivated blah, I don't care, but they deny all of their symptoms of depression. And that really can happen with long-term use. We call it the poop out effect of the SSRIs. And sometimes that's just a sign we need to change it. See, we're talking about poop all day today. The real risk with antidepressants is you have to screen for mania because they can destabilize it in kids that are predisposed to mania. That's probably a discussion for another day because most of the time the kid has never had a previous manic episode. And sometimes the use of an SSRI reveals something that you wouldn't have found unless you did it. So if you have a strong family history of bipolar disorder, or you've had an activation, restless response to an SSRI, that we need to watch more clearly. Again, this is really rare, but still important to know. Some lower seizure threshold, that is a big risk of bupropion. So we do not use Wellbutrin in people, or clomipramine in people that have seizures. And then, as I said, tricyclics and MAOIs are probably not something most people other than me are going to do. They have a lot of side effects. They need a lot of monitoring, and they're really lethal in overdose. So you really have to have a responsible parent to lock these medicines up. These can be pretty bad for kids. The problem with SSRIs and SNRIs is they scare people. They have this lovely black box warning on it. You're gonna give me a medicine that makes my kid commit suicide. Well, it's not that simple, and it's obviously much more complex. So much so that when this warning came out in 2004, everybody came off their antidepressant and suicide rate spiked and actually increased after a steady decline, because suicide is a consequence of untreated depression. And so while this is real, I've only seen it in a few cases where the SSRIs really triggered new onset suicidal thinking. And so you not only have to screen before the suicidal thoughts, and usually we pick medicines when depression is severe and the suicidal thoughts are probably already there, but this is important to monitor for because some people really do have an emergence of this, although again, incredibly rare for all the warnings we put. If you guys remember, I had given you this website before that was a great resource for parents. It also has a fabulous parent-friendly wordage for treatment of depression for kids, and really goes through why you should choose an SSRI or make a decision to just use therapy for your depression, and walks through the suicide risk in a lovely parent-friendly way to really give people informed choice. So that's a great resource to have. And with that, I have 1 minute, and we're going to stop with antidepressants and see if there's any questions.
Thank you so much, Dr. Swiger. Anyone feel free to unmute or chat in. Jenna, I noticed you unmuted.
Yeah, I have a question. How do you, so I'm thinking of some teenagers I have who are so used to their normal symptoms, which are really low depression, panic attacks almost on a daily basis, and they get some relief, which is awesome, and they're pretty satisfied with that. From my perspective, I'm like, oh, this could be so much better. And they don't have a supportive parent who's really keeping tabs on, okay, her mood's better. How do you kind of, any thoughts on how you juggle the, you know, I really think we should increase your medicine. This new normal is actually still pretty low. And communicating well with the psychiatrist maybe about that.
So think about function. So think about what are they still not doing because of their symptoms? Are they still avoiding things because they're having panic attacks? How often are the panic attacks happening? If you're still having more than 4 panic attacks a month, you probably should still think about working your medicine. Setting some really functional things that are still getting in the way. Function is our friend. We treat for function. Sometimes people are really scared about changing their medicines too, and so you want to have that. So think about function, ask about specific details about how that low mood still impacts them. Sure, it's better, and this and this and this and got better, but how still far from where you want to be are we? And then the other really simple thing is to do a rating scale. I think rating scales really help parents because it actually puts a number. This is still severe. You're still endorsing severe, or now you're moderate. You're endorsing all these severe symptoms. Now the scale says, look, you're still moderate. This is still not great. And so I think introducing those sort of more objective things really kind of helps people sort of communicate too. And that's what I urge patients to tell me, because you could just tell me you feel better, but I want to know what feels better, what still doesn't feel right, because you're right, like it's scary to put your kid in medicine, but on the flip side of that, I always sort of be mindful that the enemy of better is perfect sometimes, or the enemy of good is better. And so that line for me is function. So we're not going to achieve perfection, but are we achieving good function? And so that's something that I think really helps. And again, I think it's a little bit different for every person. I also say, and you guys have heard me say this 1,000 times, if you're not using a medicine to its full potential, you're exposing someone to all of the risks and not all of the benefits, because the risk of a medicine happens regardless of the dose that you're at. So if you're working within SSRIs or SNRIs, there's really no additional risk to increasing the dose from the current dose. Switching is a different conversation, but if I only give you 20 milligrams of Prozac and you have horrible OCD that only got 5% better, me putting you on 40 is not going to give you any more chance of side effects than that 20 did, but it may give you clear and different benefit because we finally got to where we needed. So those are my cheat lines.
I like it.
That's a great question.
Thank you, Jenna. Any other questions, comments, or thoughts? Alrighty, everyone. Thank you so much. This has been such a wonderful session. I know I say that every time, and I feel the same way every time, but it was such a great session. Thank you all so much. Thank you, Cheryl, for the case, and Dr. Swiger for that didactic. We might have to schedule for you for the last part of that didactic. I know you had a few slides left there, but we'll certainly get that in the books. The only announcement that I have today is that our next session will be on May 5th And Amanda Newhouse is going to be discussing screen time. So keep an eye out for that reminder, and I'll be sending out the recap here shortly. Thank you all so much. We'll see you guys next time.